people who go to an emergency room at a hospital are sitting in the waiting room in a hospital because of a drug-drug interaction. And every time I read that statistic, I think, wow, that cannot be true. There's no way it's that high. But that result keeps coming out, that 10% of people in an emergency room at an urban hospital are sitting there because of drug interactions. So very common. And in psychiatry, there are drug interactions that we've become very familiar with. You probably all heard that patients who have breast cancer, who are taking tamoxifen as a recurrence prevention strategy, should not be prescribed fluoxetine or paroxetine or duloxetine, because those agents inhibit cytochrome 2D6, and that interferes with the efficacy of tamoxifen, which requires 2D6 activity to be converted into its active moiety. There are many other examples of drug-drug interactions. My point is, this is clinically relevant. And reading from the top to the bottom, you can see that there are, again, differences across different antidepressants in drug-drug interactions. So we start thinking about sexual dysfunction and drug-drug interactions via inhibition or induction of enzymatic pathways. We begin to see differences across these agents. Now, this algorithm is slightly different in Canada than it is in the United States. You can see here atypical antipsychotic agents are listed as first-line augmentation in non-psychotic depression. Patients with depression insufficiently responding to an antidepressant medicine. They are, in North American psychiatry, offered an atypical, like aripiprazole, as an add-on strategy. Where the Canadian guidelines are different than the USA guidelines, in the USA, brexpiprazole, which is similar to aripiprazole, is also a first-line strategy. Brexpiprazole is going to be coming to this region very soon. Saudi is going to be getting it, I understand, in the next few months. It's going to be throughout the region. And brexpiprazole is effective and has a lower risk of akathisia than does its cousin, I'll call it, aripiprazole. Quetiapine and risperidone are effective, but they do have disadvantages. Quetiapine on sedation can make people very sleepy, can also cause weight gain. And risperidone, similarly, can cause some of these sedative effects as well as elevate prolactin. So atypicals do come with some degree of concern around some of these side effects. So when you're driving down the street and you come to the fork in the road, the question is, do you turn left, do you turn right? And when it comes to a patient who is prescribed an antidepressant medicine and have had some degree of benefit, do you stop that treatment and switch to a new treatment? Or do you add an additional agent onto the indexed antidepressant? That's the fork in the road. And in 2018, we still don't have an unequivocal answer as to which direction you should take as a guiding principle. That being said, North American psychiatry has been teaching itself, perhaps propagandizing itself, maybe, that if a patient has some degree of partial benefit on the initial antidepressant, then you should augment or add something to that to take advantage of the therapeutic gains that patients have experienced on the initial antidepressant. If the initial antidepressant was not successful, the recommendation in North American psychiatry has been just simply to stop that medicine and switch to something else. So then it begs the question, how do you define initial improvement? And initial improvement is defined as about a 20% or greater reduction in the overall depression score on the first antidepressant. And that's what patients have been telling us as well, and there's science around this. The STAR-D trial also reported this, that when patients benefit to some extent, they prefer augmentation. I apologize for the complexity of the slide. Let me just, in fact, if I can, just describe what the slide is trying to communicate, and we can just pay attention to that narrative. If, in fact, the patient has depression, North American psychiatrists and North American nurses and family doctors very often add bupropion to the initial antidepressant, whether it's an SSRI, vortioxetine, or mirtazapine. And the FDA and the evidence supports atypical antipsychotics. So we tend to see a disconnect between what prescribers do and what the FDA and the science is telling us. And a lot of the prescribers say to us, well, we're concerned about atypical antipsychotics, the side effects, long-term safety, like tardive dyskinesia. And there was a study from a VA in the United States that compared bupropion added on to an antidepressant versus aripiprazole added on to an antidepressant in non-psychotic depression. In this study, and this was the results, which are unreadable on the slide, is that the overall efficacy was better with aripiprazole, but the tolerability was better with bupropion. So in my office, I tend to recommend atypicals as first-line strategies. Use lower doses, and I have found, in fact, in the case of aripiprazole, 1 to 2 milligrams, maybe 3, to be sufficient for most patients. Now, pharmacologically, we have a reality, and here's the reality. The reality is 15%. 15%, 1-5. What do I mean by that? If you see a doctor or a nurse for depression, and he or she gives you an antidepressant and it's not successful, he or she gives you a second antidepressant, either as a monotherapy or as an add-on, and it's not successful, we know that there's only a 15% chance that the third one's going to work. There's an 85% chance it won't work. So 2 points. One is that we've got to get our initial antidepressant selection better and optimize it, because the window of opportunity begins to close very quickly. And then secondly, we need very different treatments. Recently, in the last 8 months, 9 months, in Toronto at my center, we established what we call a rapid onset antidepressant center. And the idea is to provide patients very different treatments. So ketamine was discovered by a company, Park Davis pharmaceutical company, developed this in 1962 as an alternative to PCP, phencyclidine, for anesthesia. And the U.S. Food and Drug Administration approved ketamine as an anesthetic in 1970. During the last decade, we have replicated evidence now that ketamine delivered through various routes, including but not limited to the intravenous route, has been shown to attenuate depressive symptoms in treatment-resistant depression. And the results are not just significant, but observable within 12 to 24 hours. And this is something that we've been seeing as well. Johnson & Johnson is also developing an intranasal formulation of ketamine, which is in fact going to make it to this region as well, as far as I know. The odds ratio of improving depression in patients who have had insufficient outcomes, in many cases with a dozen different treatments, has been startling, with odds ratios approaching 8 to 10, that these patients can benefit within 24 hours, and some of these patients are sustaining the benefit out to 1 week, out to 1 month, maybe even longer. Now, when we attend a meeting like this, we are also attempting to find out what does the future hold in terms of where we're going. And ketamine has been a very interesting opportunity for us. We use it extensively at my center. There's another product called Rapastanil, which is on the board now. And Rapastanil is not commercially available yet. It's made by a company called Allergan, who makes Botox. And this is a company that is developing this treatment, which is similar to ketamine, but unlike ketamine, it doesn't have some of the safety concerns, such as dissociation, which is associated with the use of ketamine. We're developing this drug at my center as a rapid onset treatment for adults who have treatment-resistant depression. So it's one of many treatments that we're looking at in this space. Just to fill in some of the other treatments, nitrous oxide is also being developed at my center, which you would know as a gas. It is an inhalational treatment that patients are taking, actually for the treatment-resistant population. I'm working very closely with a company called Alchemist, and Alchemist is based in Boston, Massachusetts. And this is a very interesting molecule. It's a combination medicine that brings together buprenorphine and samidorphan. So just a reminder that in the human brain, we have 3 different opioid-ergic peptides. We have the endorphins, the enkephalins, and the dynorphins. And we all remember the beta endorphins. They are cleavage products of pro-opiomelanocortin. And we have 3 canonical or orthodox opiate receptors. We have the kappa, we have the mu, and we have the delta. And buprenorphine, which people would know as a treatment for opioid use disorders, is a mu agonist and a kappa antagonist. And samidorphan is a kappa antagonist. This combination treatment has now been shown to be a rapid onset, effective treatment for adults who have treatment-resistant depression. I remember when I was a resident in psychiatry, wasn't that long ago, but it's getting longer now. And when I was a resident in psychiatry, putting together a protocol to study ACE inhibitors. Many of the room remember captopril. Captopril is an ACE inhibitor. In ACE inhibitors, angiotensin-converting enzyme drugs for cardiovascular disease like hypertension, also inhibit encephalolinase in the brain. And we hypothesized that using an ACE inhibitor would improve depression, improve mood in depression. And it's interesting that we now have the very first opiate-ergic drug primarily being developed for the treatment-resistant depression. This year is a meta-analysis of a study we did at my center looking at minocycline, and this is something very different. You've probably been hearing about anti-inflammatory treatments now being used in depression. Minocycline is an antibiotic. It's part of the tetracycline class. And we've shown at my center that minocycline can affect the peripheral inflammatory homeostatic network. We use it as an antidepressant at my center. And this was part of a growing interest not only in inflammation, but also in anti, pro, and prebiotics as potential treatments and prevention strategies in people with depression. The dose that we typically use is around 50 milligrams a day for a couple of weeks. I won't say a whole lot about neurostimulation. Electroconvulsive therapy remains the gold standard treatment for treatment-resistant depression. It is the most effective treatment in all of psychiatry. It's the most effective treatment in all of medicine. Transcranial magnetic stimulation is not as effective as electroconvulsive therapy in treatment-resistant depression, but TMS is certainly much more acceptable to patients, and obviously that's an important part of the overall effectiveness of the treatment is its overall appeal and acceptability. Other types of neurostimulation, magnetic seizure therapy, and others are certainly being developed and being looked at, but I wanted not to forget mentioning ECT as really the first line gold standard treatment. What about some of the physical and meditative treatments? Well, this is something I've had an interest in, aerobic exercise, both resistance and aerobic exercise, both have been shown to attenuate depressive symptoms in adults with depression. Other types of interventions like chronotherapeutic interventions, very interesting data now looking at partial sleep deprivation, maybe even changing some of the time of the day that you're sleeping. Can have a powerful effect on depression outcomes. One of the very first patients I saw with bipolar disorder, I remember giving this patient sleep deprivation for treatment-resistant depression. Also, on a separate note altogether, there's really interesting data in the world of metabolism that the chronobiology affects your propensity to obesity. Said differently, you probably all know this, but the science is actually confirming what you do. And that is, if you take in calorie after 1 o'clock in the afternoon, most of that calorie is just deposited as fat. And so if you're going to eat during the daytime as humans, you probably shouldn't be eating after 12 or 1 o'clock. And it's really an interesting point because it speaks to not only aspects of physiology, but also speaks to something that's relevant to the brain, and that is in fact changing the chronobiology. What does that mean for the brain? What does that mean for the body? Naturopathic medicines, now in Canada, just a couple of days ago, they legalized marijuana. My patients think that weed is effective for depression. Cannabis is not effective for depression. Cannabis is a very serious and toxic medication to the brain. particularly THC9. But there is a testable hypothesis that cannabidiol could be actually beneficial for the brain, but we don't know that yet. There was a report back in March that cannabidiol is an antipsychotic in schizophrenia. That needs to be replicated. We don't know that's a fact just yet, but it's a testable hypothesis that cannabidiol can be brain therapeutic. Undeniably, THC9 is a brain toxin inducing cognitive impairment, psychosis, and anhedonia. You can see on the slide a variety of other interventions that are in the so-called complementary alternative medicine category. Some parts of the world embrace these treatments more than others, but I would say that for most of the patients that we are seeing, in fact, these agents are not sufficient. You see St. John's wort, it has evidence. I would never give a patient St. John's wort. The evidence does support in some European data that it could have a signal of efficacy. I'm actually quite underwhelmed with St. John's wort. I don't think it really works, and it does cause serious drug interactions. So I personally have not embraced most of these particular naturopathic medicines, but we are certainly beginning to look at cannabidiol as a potential approach. So to keep myself on time, I've got 17 seconds left. I'm going to summarize by saying that we've got a very common condition. I'm obviously taking a very micro perspective that is focusing on patients who've been diagnosed accurately and in a timely fashion, who are motivated and engaged to be in the healthcare ecosystem. We need to do better than 20%. Only 20% are receiving best practices. Try and get that better so we can improve the overall outcome. But I'm now convinced that all of this is very academic, and as we motivate these patients to work with us and really work with this overall game plan in the long term. Folks, I'm going to stop there, and thank you very much.
I'm sure it needs a lot of time to cover such a topic, especially by Professor McIntyre. But we'll try to stick to the time so that we listen to both talks, and then we'll try to spare some time for discussion. Please, I'm sure it's very important. Allow me to call for the second speaker, Dr. Tammy Benter. She's a psychiatrist in chief and chair at the Children's Hospital of Philadelphia, Department of Child and Adolescent Psychiatry and Behavioral Sciences. And she's associate professor in psychiatry at the Perelman School of Medicine, University of Pennsylvania. And leadership role at the Children's Hospital of Philadelphia also includes Secretary of Children's Hospital Philadelphia Physician Practice Association. And she's a member of the Executive Committee of the Medical Staff, Director for Child and Adolescent Remote Clinical and Research Program for youths with depression and bipolar disorder. This is only the first paragraph, and she kindly accepted just to read the first paragraph. Please welcome Professor.
Thank you very much. I'm honored to be here among my colleagues to talk about pediatric eating disorders today. We have a lot of material to cover. I'm not sure I'm going to cover it all in 30 minutes, but I did want you to be aware that all of the slides will be available on the conference website, so you'll have access to them. I would like to ask you, how many people in this audience have previously treated children with, or adults with eating disorders? Okay, that's a good number. So that'll be a nice start. I wanted to mention I have no disclosures and no financial conflicts of interest. So the topic today is 5 things that every mental health professional should know about pediatric eating disorders. And the reason that I say that everyone should know this, even if you never treat them, is that the number of mental health professionals is quite limited, and the number of eating disorder cases that we're encountering is quite large. So that the initial treatment for eating disorders, excuse me, among any population may start with their mental health provider. So today, my goals are to help you recognize the common eating disorders of childhood, to recognize the signs and symptoms of pediatric eating disorders, to discuss ways that the pediatric eating disorders differ in the pediatric population than the adult population, and to spend a little bit of time talking about the evidence-based treatment for eating disorders and a few of the challenges that impact our capacity to effectively treat eating disorders. So what are the feeding and eating disorders? They're very similar of childhood. They're very similar to the adult disorders. What's unique is the developmental presentation of those disorders. So most of you are familiar with anorexia, bulimia, binge eating disorder, a new diagnostic category called avoidant restrictive food intake disorder, commonly referred to as ARFID. Pica and rumination disorder are typically specific to the pediatric population. We won't talk about those disorders today because those are actually not eating disorders, but feeding disorders. And then we won't talk about the other specified feeding and eating disorders. What I will highlight today is not the diagnostic criteria in the DSM-4 or the DSM-5, but we'll focus specifically on the core elements of the disorders. So anorexia nervosa, as many of you know, has some significant changes in the DSM-5, and we'll talk a little bit more about that as the presentation progresses. We're going to talk about bulimia nervosa and binge eating disorder. Binge eating disorder is a new addition to the DSM-5 as its own diagnostic category. It was previously listed in the OSPED section. And then avoidant restricted food intake disorder is very new and very relevant to the pediatric population. This population of kids referred to as ARFID were those children frequently admitted to the hospital who did not have body image distortions, but had all the other complications of anorexia nervosa with low nutrition, low weight gain, poor growth. So with anorexia, the core features of anorexia are restriction of energy intake relative to requirements.